And this is from Dr. Joseph Erinjeri, who is interventional radiologist and physician scientist at Memorial Sloan Kettering Cancer Center. He's going to give us a presentation on cryoablation as a treatment for desmoid tumors. Thank you, Dr. Erinjeri. We always appreciate your participation.
No problem. Can you hear me okay?
Yeah, looks like you have a work day today anyway in your
Yeah, we're in the OR, and actually after this, I'll be back to the OR today. But it's always a pleasure to be here with the Desmoid Tumor Research Foundation. I think the real stars of the show at the Desmoid Tumor Research Foundation are the patients, who are always coming up with great ideas to help push this research along. And I know many of you are my patients, and really have pushed me to develop new techniques in cryoablation. So let me kind of share with you. Let me get my screen. Oops, let me get my screen shared, and then we will kind of share where we're at right now with cryoablation for the treatment of desmoid tumors. Make sure you're seeing the screen. Okay, are you guys seeing the screen?
Perfect.
Okay, great.
Yes, we're good to go.
Okay, perfect. So as you know, desmoid tumors frequently recur after surgery, and we've seen many papers on this, and this is no secret. And this is what has influenced all of us in the community to look for other treatments other than surgery. And in fact, in some studies, up to 30% of patients undergoing desmoid tumor resection will recur. And so despite the high recurrence rate of surgeries, it's still often the first treatment. And normally the way this goes is you've got a symptomatic desmoid patient, and they frequently go on active surveillance for a while to see what the growth rate is. And when they have progression, that's where we have this decision point between surgical resection or systemic therapy. And then if there's disease progression after that, it's usually systemic therapy. We call the group kind of before this line the first line therapies, and we call the group after this line the salvage therapies. So we often ask, what are the other therapies that could be used for primary or salvage therapy of desmoid tumors? And there are several that have been tried: RFA, cryoablation, HiFU, and now more increasingly DebTase, which I'm sure in some part of this foundation seminar you've heard about. Today, we're going to talk mostly about cryoablation. The concept of cryoablation is not so complicated. We know what happens when you use an aerosol bottle and it gets cold. When a gas expands rapidly, there is a physics effect called the Joule-Thomson effect, which basically causes gases like nitrogen, argon, or CO2 to cool when they rapidly expand. And so here is actually a prototype of the first cryoablation needle that was created. And this is from the actual patent application. And and by the way, it's not mine, it's somebody else's pictures. But here you inject argon through the center of a small needle. The gas expands near the tip. That causes rapid cooling of the tip, and then the gas is vented out. The temperatures that can be achieved with this type of system are in the order of negative 150 degrees centigrade. And interestingly enough, different types of tumors have different thresholds for dying. And you'll notice that in the second to last line here, sarcomas in mouse have a very low temperature of about negative 60 degrees. And that's probably similar to desmoids. It's one of the reasons why aggressive cryotherapy is necessary to kill desmoids. And if you just kind of lightly cool a desmoid tumor, maybe to negative 10 or even negative 20, you may not get a really good effect. I won't bore you with some of the work we've done looking at the basic science of cryoablation, but I will tell you that what we know is that there are factors that are involved with optimizing cell death in cryoablation. And one is the target temperature. Colder temperatures are better. Some are the time to target temperature. Cooling faster is better. Some are the time at target temperature. Longer is better. and then repeating the freeze-thaw cycles is also better. So we know kind of how to optimize cryoablation to make it more effective. I just wanted to show you one picture of what it actually looks like under a microscope when you freeze a cell. This is actually a Chinese hamster ovary cell. And this is, it's put on a special microscope where you can look at the stage actually cools to low temperatures. And you can see at -3 degrees, you can see these black ice crystals. They're black under this type of microscopy, just starting to touch this cell. You can see that once it reaches -20 degrees, you get the ice crystals traversing the cells. And then at -40 degrees, you can see the cell itself is completely frozen. And notice how it's no longer this nice spherical cell, but it's all irregular. That's because those ice crystals have actually broken the cell membrane and the cellular components have leaked out. And so slow cooling is bad because it only causes cellular dehydration. Whereas rapid cooling causes this intracellular ice formation, which is the harbinger of cell death with cryoablation. I show this one slide, and it isn't for self-promotion, but it's mostly to say that, and I've probably spoken at this meeting 5 times, and it's taken a long time for me to publish a paper where I was able to, I feel like strongly say that we think cryoablation provides disease control for extra-abdominal desmoid fibromatosis comparable to surgical resection. And I would say this isn't published in some radiology journal where we have all our friends reading our papers. This paper was published in Annals of Surgical Oncology. It did take several years to get it published, even after we wrote the paper, kind of convincing the editors of this journal that we thought this was an important piece of the literature that surgeons should know about. I want to just show some of the data from this study, which came out in 2022. And this is non-randomized data where we took 22 patients who had cryoablation and 33 matched surgical patients that were matched using propensity score matching. And when you look at patients that had one treatment with cryoablation versus one surgery, what you see is the curves are fairly overlapping, and maybe as time goes on, surgery is a little bit better than cryoablation. But after multiple treatments, and so where we can go back and touch up areas where the first cryotherapy didn't work as well as we would have liked, you can see that cryoablation is actually at least comparable and perhaps even superior if we had bigger numbers. Now I can't really say that. You see the p-values are both greater than 0.05, but we can at least say that the disease control is comparable both after one treatment and after multiple treatments. We looked at risk factors that would predict recurrence after cryoablation, and we found 3 strong ones. One was the size of the tumor. That is, bigger tumors tended to recur more, that younger patients tended to recur more, especially those who were less than 25, as well as patients who were treated in the salvage setting or the recurrent setting did worse than those who were treated in the primary setting. And it's another reason why we really, in our multidisciplinary group here at Sloan Kettering, we kind of work together to try to move people away from surgery as a primary therapy towards other therapies like cryoablation. And when we produce this nomogram, where we ask the question, depending on how many risk factors do you have, what is your risk? You can see that for patients that have 0 or 1 risk factor, these patients actually, in our study, actually had no local recurrence. Whereas if you had 2 or more risk factors, you actually had a much higher local recurrence. So of course, we're always looking in our multidisciplinary group to find the patients that have the right risk profile to put forward for cryoablation as their primary therapy. The most common side effects that we tended to see post-cryoablation were some degree of pain. Most pain resolved within hours. 50% of patients will go home the same day. 50% will go home the next day. In general, for the patients who do have pain, that pain can peak usually, frankly, around 2 weeks. and not 2 weeks, 7 to 10 days. And that's because the inflammation continues to grow as the body is reacting to the dead desmoid tissue inside the body. Here's a case. This was a patient with a 32-year-old patient with a painful rectus desmoid. Here we are showing a picture where you can see the tumor here. Now under CT guidance, you can see that we've put some contrast to push the liver away from the abdominal wall. And we've got the cryo needle in place. And you see this low attenuation or dark gray ovoid structure. That's the actual ice ball. That's the ice ball forming underneath the skin. You can see that we've put some fluid in the skin as well to puff the skin up. And then when we pull the needle out, because this, it makes it much more clear, you can see the tumor. And then there's this lighter gray area, which is the ice ball surrounding the tumor. When we look at this patient 48 months post-procedure, you can see there is almost, you can almost not see where the desmoid tumor is. What happened to the tumor? The body has a set of garbage collector cells called macrophages. They come in and eat up the dead collagen and take it away. Here's another patient who's a 20-year-old, in this case with a painful right intrathoracic desmoid tumor. And you can see in a couple of projections, it's quite large. It's trying to get in between the ribs here. This is what a kind of a very large cryo case would look like. The patient is under anesthesia, and we're putting, in this case, it was like, greater than 10 cryo needles into the patient. And then you can see actually the frost that's forming over the needles as we're freezing. Here's again a couple of pictures with the cryo needles in place. You can see the low attenuation ice ball in both the right and left images, one with the needles in place and one with the needles removed. This was the pre-picture. You can see 12 months post. We've got a small area of recurrence. And as I mentioned, this is okay because with cryoablation, since it's minimally invasive, we can go back in and touch that area up. And that's exactly what we did. We put another needle into that area. And after 3 years, you can see this area continues to not have enhancement anymore, and the area continues to shrink. Here's another patient, just an example of doing cryoablation in a difficult location. Here is a patient with a desmoid tumor that is deep to a implant. We weren't sure how this would affect the implants. The plastic surgeon was willing to take the implants out for us to do this procedure. We said, let's give it a shot and see if we can do this without injuring the implant. And you can see we've actually got the ice ball surrounding portions of the implant. And 3 months post-cryo, we've got a good effect on about 70% of the tumor. You see there's still a little residual tumor in the bottom right corner of the implant area. So what do? We go back in a second time, place a second needle from a slightly different approach. And at 9 months post the second cryo, we've got a good treatment response, and this person has not recurred. Got a couple more cases to show. Here's a 31-year-old with a very small desmoid tumor, but it's sitting in a tough spot right above the bladder. And so again, we can use our same techniques where we put some fluid inside of the pelvis to push the bladder away. We also put a Foley catheter in the bladder to decompress the bladder. We see the tumor with the ice ball surrounding it. And I don't remember when the follow-up was for this one, but you can see we no longer have the enhancing mass in that area. Now, I'd say prior to this year, this was a patient with an 8-centimeter abdominal wall desmoid. This is probably a size that in the past we would not have cryoablated. You can see here's the outline of the tumor, and especially because you see it's in basically close proximity to the bowel. With a tumor this large, typically we cannot put fluid in to separate the bowel and the tumor. And we've been working on a technique akin to laparoscopy, which is CO2 insufflation. So in this case, we actually access the peritoneal space, and we put CO2 inside the peritoneal space to push the abdominal wall away from the bowel. And that actually can sometimes also compress the bowel a bit. So now you can see that we've got good separation between the tumor and the bowel here. And now you can see a post picture where we have the ice needles that have just been taken out, and we have this low attenuation ice ball around this person. This is from a very recent case, so I don't have the follow-up, but we're very excited about this technique because we think that CO2 insufflation of the abdomen will be a powerful tool to allow treatment of larger abdominal wall desmoids. We always have to worry about the complications. We are close to the skin often, and frostbite injuries can be a problem. As long as the area of freezing is smaller than about the size of a dime, it will heal on its own. I've never had to do a skin graft, but skin grafts are something that sometimes have to happen to cover up an area where there has been a frostbite injury. And then, of course, nerve injuries. These are the most challenging things. The ice is very effective at killing the tumors, but it can kill the nerves that are adjacent, particularly in the extremities. There are new MR-guided cryosystems that are coming out. The equipment typically right now is not that great. We're hoping those new systems will be more effective. So in conclusion, cryoablation of desmoid tumors can achieve long-term disease control, both in the first line and salvage settings. And I think this is probably our great accomplishment as a team here in the Desmoid Tumor Research Foundation, patients and scientists together. Cryoablation is an appropriate treatment consideration for select treatment-naive patients with extra-abdominal desmoid tumors. Thank you very much.
Thank
and I
you.
will take questions.
Yeah, we have so many questions. Can you please share what the training entails for an interventional radiologist learning how to cryoablate desmoid tumors? How many of these procedures per year does Sloan Kettering perform? And about how many locations would there be interventional radiologists who really you could go to get a good procedure?
I think it's not so much. I'm sure there are interventional radiologists across this country who are technically experienced and routinely do cryoablation for renal tumors and lung tumors. But I think what really sets any desmoid center apart is the multidisciplinary care. I think that's really the difference. So when you go to a center, and I don't think it's just the technical aspects, I really think it's the team approach that makes a big difference. We do on the order just for desmoids, we probably do 30 a year, which I think is probably a high number. And a lot of places, I think, they might only see this like once a year or less. So I think we have a center of excellence, which is great, but I think as we publish more about this, we'll be able to see more people engaging it throughout the interventional community.
Okay, somebody from Canada said, are there any clinics in Canada that perform cryoablation? I just don't know the answer to that question. I don't know those people that well. I'm sure they do cryoablation for other things. I just don't know if they do them for desmoids. So how does somebody decide that they could go to a center? How does a patient make that decision to seek a center, travel to the center?
Yeah, I think the first thing is you've got to first have a therapeutic relationship with the doctor. You got to meet the doctor. He should see you in the clinic. He should be reviewing your scans. He should be following you for a certain amount of time. And I would encourage patients that ask the right questions, which would probably be, do you treat desmoid tumors? Are you part of a multidisciplinary team that treats desmoid tumors? Do you perform cryoablation? If you do you do it only for desmoid tumors, or do you do it for other tumors as well? How many of these procedures do you do a year? I don't think these are insulting questions. There are things that I don't do a lot of, and I just tell people, hey, I could happily refer you to somebody who might do more than this than I do. But those are the kinds of questions I'd be asking.
That's so helpful to have those questions. Thank you. What percentage of cryo treatments lead to nerve injury in your experience?
So I think in our practice, if I quote people, I think the risk of nerve injury is on the order of 1 to 2%. I think though that when you're in the extremity, it's just so hard. And you've got to be so careful. The main risk would be in cases where the tumor is abutting nerves. I think it's really, as I mentioned, you have to get a really fairly aggressive freeze in order to not have a recurrence. And this is always the trade-off, is how much is the recurrence going to be versus how much is the risk for injury to adjacent structures like nerves.
Okay, again, who would be clearly excluded from this kind of procedure? One question is, so this can definitely not be done with a desmoid near a mesenteric artery?
Yeah, notice we talked about extra abdominal desmoids, intra-abdominal desmoids. Pretty much cryoablation is not an option for.
For intra-abdominal.
Correct.
All right, Dr. Erinjeri, this patient says, I've been watching your presentations at the DTRF meetings for years, and I just want to say thank you. Thank you for continuing to pay attention to this community and to advance and innovate this treatment to be an option for more desmoid patients.
Well,
I
that's such a
totally
nice
agree.
thing. Makes me feel wonderful, and I do feel a kinship with these patients, and I think that it's nice to I'm sure after going around to see a lot of doctors, it's like maybe the first time they heard of it, or maybe heard of it at some point, in a book. And when you meet somebody who, oh yeah, we see this all the time, like that must actually feel good.
Couple other questions comparing the cryo to the effect of sorafenib, for example, and how often do you see regrowth after a procedure?
Good, both good questions. I think that as I think the number is 60% of patients get a treatment effect with sorafenib, and I'm sure as time goes on, the newer agents will have even higher response rates. For us, we have, if we look at that cohort of patients, about 2/3 of patients will get complete disease control with one treatment. 95% of patients will get disease control with 3 or less treatments. 5% of patients will not get disease control with 3 treatments, and they will often go on to either a targeted therapy or a cytotoxic chemotherapy like Doxil.
Okay, very helpful. Dr. Rathan, you came on. What would you like to say?
I think Dr. Erinjeri has it right. I think it also depends a lot on, I think we tailor the therapy to the patient, as I know that they do at Memorial Sloan Kettering, right? So an intra-abdominal desmoid is not going to get cryoablation. Someone who's got a superficial desmoid in the abdominal wall, it might be a great fit. And I think, as he said in answer to a previous question, I think the secret sauce is really just making sure that the right people are involved, that the cases are discussed carefully, and that therapy is matched properly to the patient.
Yeah, there are people that get operated on, that it's the right therapy for them. There are patients who want cryo, and I say, listen, you got to try sorafenib. You got to try you got to try these therapies. You got to think about a trial. And I think when you hear the same reinforcement from different parts of the multidisciplinary team, I think that helps to really strengthen the confidence that we have in the treatment. So yes, I completely agree with Dr. Rattan.
Excellent point, bringing it back to the multidisciplinary team and how important that is. Wish I could go on and on. Lynn's telling me I have to close. Thank you, Dr.
No problem. I got to run too.
And
see you later, guys.
Yeah.